the best place to start is that as a country, okay, we are aging. As a world population, we are aging, okay? So if we look at all of this, by 2030, okay, the U.S. population over the age of 50 will increase to about 132 million. Okay? In this time, the number of adults that are going to be 65 to about 75 is going to double, okay, to about 38 million. So by 2030, 1 in 5 people will be over the age of 65. 1 in 8 people will potentially be over 75 by 2040. You can look at this in one of two ways, okay? The first way is, oh God, we're getting old, okay? The country is aging, we're shifting our population in that way. That's partially, the number of people that are over the age of 50 is going to become a larger and larger percentage of all U.S. population. Part of that is due to declines in birth rates, okay? We can also look at this as people are now able to live long. We are better able to, from a medical standpoint, to keep people alive. That's good, okay? So having a larger percentage of Americans that are getting older, okay, can be viewed as a very good thing. But it comes with consequences. Some of those consequences are going to give many of you jobs, okay? They're going to require the need for physical therapy, occupational therapy, doctors, physician's assistants, okay, et cetera, et cetera, et cetera. So we've got to understand in some ways what's happening, and then what role can we play in you guys now, and then in folks that are my age, and then even like your parents' age, to use exercise and physical activity to try to kind of attenuate some of the negative consequences. Okay? So here we have the percent increase in people that are 65 and older by state. Okay? And so the darker the blue, then that's the larger the increase. This is from 03 to 2013. So you can look at all of this, like everybody is increasing, but we're really kind of going up in some other places. So this is a big deal. It's happening everywhere. We're not going to talk that much about what's going on in Kansas and West Virginia or even New York. Why are they not aging like everybody else? Okay? But there are things that happen from a physiological perspective. Okay? Things happen in the nervous system, things happen in your bones, things happen in your muscles, in your cardiovascular system. These are going to change, and they're going to have an impact on proper function. Okay? So if we look at, this just makes me always think of the little guy in Home Alone, and all of this to sort of Grandpa rocking his really, really cool robe here and his walk. As the sort of neuromuscular or the motor system ages, the biggest thing we're going to see is a loss of muscle mass. That is accompanied by a loss of strength, okay? Accompanied by a loss of strength. Much of this you guys won't see until maybe your mid-40s or 50s, okay? You're going to be fine for a while, but it really begins to fall off the cliff, and we'll talk about why in a few seconds. This loss of mass and loss of strength is going to be accompanied by a decrease in function, okay? You can't walk as well, you can't jump as well, you can't run or ride a bike, or go upstairs, all of these things. Your speed slows down, you have a decrease in dexterity, right? So your fine motor skills are going to lose, are going to go away. And then all of these things together increase our risk of falling, and that also increases our risk of becoming disabled. Because when I fall, because I lack all of these things, I'm going to fall and I'm going to break my hip because of changes in the skeletal system that we'll talk about later. Okay? But our big issue is it increases disability. Right? So people can't get around, they can't live the life the way they want. What's the point, right, in some ways of living a long time if your life sucks and you can't do what you want? Okay? I want to be able to ride around at like 85 in a golf cart and like yell at people and be real fussy and cheat at golf as much as I want at about that age. We'll see how that goes. Okay? So if we look at all of these kinds of things, okay, the decrease in strength in many ways is going to happen regardless of what it is that you're doing. Regardless of who you are, regardless of your exercise history, okay? But we typically see about a 10 to 20% decrease in people sort of per decade when you're under 60, okay? So if we look at all of this, this one is depicted in kind of as this straight line that drops. There's some other evidence that it looks more like all of this, that it's pretty flat, and then kind of out somewhere around 50 or 55, it really begins to get. But the important thing is that you're going to lose until about 60, you're going to lose some strength. A lot of this is just due to disuse, okay? It's due to disuse. You guys are young. I've been looking at all these capstone surveys of how much people exercise and they do things. You guys are very active, right? You go, you work out, and do things. As you get old, like me, your time to do that is going to decrease. And you have to make choices like, can I spend 10 minutes here to rest on the couch because my daughter is crazy, or am I going to try to go to the gym and work out, right? Or, boy, I saw that commercial for the Peloton, but I don't even know that I'd have time to do that in my house in that way, okay? So a lot of this is from disuse, and so some of this we can deal with by trying to be more active. You do tend to see after the age of 60 in both men and women an accelerated decline in strength. Okay, it's going to go down even faster as we do all. So if we look here, this is the thing that I want you guys to try to understand about why a decrease in strength is so important. Okay, imagine that. Okay, I say, Tessa, stand up. Tessa, stand up. Okay, sit down. Stand up slowly, slow, controlled, slow. Okay, back down. All right, thank you. Okay. It took a certain amount of strength and coordination for Tessa to do that. Okay? There is some critical amount, some critical strength that she needs to stand up fast and to stand up slowly. Right? That's based upon how much does she weigh, what are her biomechanics, there's some things that go into that. But there is some critical level of strength that she did not have. She couldn't do that. Okay? That is what is being represented here in the kind of pink or peach colored here, is that there is some critical amount of strength that a person needs to go from sitting to standing quickly, okay? Which is what we talked about in the previous lecture. When we look at gait, we go from stand up, walk. That's one of our ways to assess function. So we need a certain amount of strength to do that. And then we need a certain amount of strength to do that slowly. And once we fall below this value, you can't do it anymore. So one of our goals with aging, or with our kind of dealing with aging, is to try and do one of two things. Either make you so strong here while you're young that even though you're losing strength, you started off so far ahead of this that even as it declines, like we're seeing here in blue, even as it declines, you're going to stay out of kind of the bottom part of this area. Or that I'm going to take somebody and I'm going to try to maintain your strength for a longer period of time by doing some activity and training so that, again, we prevent you from kind of falling out on the bottom of the okay? Does that make sense? Okay, this idea that there is a critical amount of strength that you need to do something. All right? Okay, so the age-associated loss of muscle mass, and this will absolutely be a question on the test, the age-associated loss of muscle mass is termed sarcopenia, okay? Sarcopenia. So that's muscle mass. Associated with sarcopenia and the loss of mass is also a loss of strength. Like sarcopenia itself is losing muscle mass. We see a decrease in the entire cross-sectional area of the muscle. So here is a quad of like a 25-year-old, And then here is a quad of somebody that is, say, maybe 60 or something. So here, this area in our hamstring area, the area has gotten smaller. So that's sarcopenia. We see both a decrease in the size of muscle fibers. Remember, you're born with all the fibers you're ever going to have. When you train with resistance, those fibers get bigger. So the individual fibers begin to shrink. It's not great. But then another consequence of aging is that some of your muscle fibers will die. Okay? They will die. That is most likely a consequence of death of the motor neuron that connects to them in the spinal cord. Okay? Motor neurons, especially motor neurons from fast twitch muscle fibers, seem to be particularly susceptible to neurotoxins, to an accumulation of these things like we would probably classify under what we called stress. Okay? All of you have eaten some neurotoxin probably today. Okay? Or yesterday, or something. You're all accumulating in tiny fractions of a bit by fractions of a bit, and eventually you'll have enough that it will kill off an alpha motor neuron. Okay? As the motor neurons die, the fibers they connect to can also die. So the fibers that I have get smaller, and I begin to lose some, and so that's why my muscles are going to begin to shrink. Okay? The most susceptible muscles to sarcopenia tend to be the large weight-bearing muscles. Glutes, quads, plantar flexors. Okay? They're the ones that are the most susceptible. And so part of this thing you can hopefully understand is that if I can stay active and use those muscles, there's less of a chance that I will use them. Okay. So, as I told you, right, we are going to see preferential loss of type 2 muscle fibers from cell death. Okay? So, when you look at the individual fiber type percentages in older individuals, you will see the beginning of a shift of them having fewer fast twitch fibers and more slow twitch fibers. Okay? So here are some data from some very, very highly trained individuals that were highly trained when they were young and maintained their highly trained status as they aged. Folks that were, we're calling them fitness trained. They were, right, they were doing kind of like recreational activities. They were pretty trained, but not like super duper kind of like Olympic athletes or even collegiate athletes, things here. And then here are untrained people. And what you can notice is the higher the bar goes, okay, the greater the percentage of all muscle fibers that are slow twitch. And so you'll see our highly trained folks look pretty much the same, but in our fitness trained and in our untrained people, we are sort of increasing the amount of slow twitch fibers that we have as a percentage of our total. This is mostly due to a loss of type 2. You also tend to, within your type 2, if you're going to lose some, you tend to lose the type 2X fibers, okay, rather than the type 2As. So you're losing your largest and your fastest twitch muscle fibers. There's a reason that grandma is no longer a sprinter. There's a reason that grandma takes a long time to turn the wheel of her car, right? Older people are slow. Part of it is just straight physiology. Their fiber types have shifted to become more slow. Okay? There's real world consequences to these things. Let's talk about the skeletal system. Right? You've lost muscle mass, that's sarcopenia. You are also going to lose, and this is especially common in women, you're going to lose calcium from your bones as you age. This is a process that is called osteoporosis. Osteoporosis. We'll talk a little more about osteoporosis next week when we do kind of skeletal system and physical activity kind of changes that are going to be there. Okay? But as we lose bone density, then the increased risk of fracture goes way up. Okay? The bones are no longer as strong as they used to be. So when you fall or you get hit on the arm or the hand or something like that, the bones will break more easily. You also are going to see decreases in elasticity of connective tissue, which can create movement issues. That's going to lead to decreases in range of motion at joints. Your tendons become more stiff. Because of that, there's an increased risk of tendon injuries. Okay? Much of these changes, outside of menopause-related declines in bone mineral density, most of these changes are likely going to be due to decreases in physical activity, decreases in exercise, resistance training, and things as we age. We become less active, we do less training, and it has these very pronounced effects. So the positive is that maintaining physical activity, maintaining resistance training, okay, into older age can prevent or at least attenuate a large amount of these things. A large amount. Sometimes there's stuff we can do about osteoporosis. There's not as much. We'll talk about this next week. Ladies, you've got about 5 years. You better start resistance training right now if you haven't ever done it. Because you need to get your bone mineral density as high as it can be. Because by about 30, it's going to start to decline. Okay? It's going to start to decline. You're going to hit menopause. You want it to be as high as it can so that once you hit menopause, it doesn't fall to levels that are going to be unacceptable. Okay? If you want to know what your bone mineral density is, volunteer for my PhD student study. You get a DEXA scan, she'll tell you your bone mineral density. Okay, so there's also going, so we've talked about muscle, we've talked about bone, let's talk about the nervous system. We'll mention that a little bit, okay, as it relates to muscle, but there is going to, due to lack of blood flow, due to neurotoxins and the accompanying what we call apoptosis or cell death that is going to be caused by these two things, we are going to see decreases in the number of neurons in the brain and in the spinal cord. Okay? That is going to lead to decreases in reaction time, coordination, fine motor skills, speed, okay, all kinds of things. Then there's going to be, as a consequence of things going on in the brain, there may be cognitive decline, memory loss, okay, and things like that. So kind of beyond the scope of our class. So there's going to be these age-related changes here. They're going to also have further impact on cells. Okay? If we look at this, strength declines are not uniform. Okay? We tend to lose more strength as we age in muscles you don't use very often, which probably makes sense. We lose things in concentric or shortening contractions, more so than isometric or eccentric. We have a greater loss at high contraction velocities. We have greater losses than in power or kind of jumping ability, sprinting ability, kind of power activities. And women tend to have a greater loss than men. A lot of this is nothing about an actual sex difference in physiology. It's much, much more so just driven by women tend to, at least in the class, have tended to do less resistance training than men, but to lose physical activity, become less active as they age to a greater extent. Okay? So, again, though, if we can continue doing things, and I always kind of laugh at this and make light of it, but if we sent grandma to CrossFit, they'd use a lot of different muscles, okay? There'd be lots of concentric contractions, they'd be trying to go fast, lots of power activities, no matter how bad she is at doing a power clean or a hip up or something, okay? But if we can keep doing these things, okay? If we can keep doing these things, we can prevent a lot of this loss. Okay? We can prevent a lot. So here's my dude about to either do a power clean or probably a deadlift is going to be my guess on these things. for preventing the effects of aging, especially on muscle and bone, you need to do resistance training. Okay? You need to lift weights. You need to lift somewhat heavy weights. Okay? As heavy as we can. That can be dangerous in some older populations. You need to lift weights. That's going to be a really, really big thing. Okay? So, is it safe? Yes. Is it effective? Yes. Now, you can be alone and just take growth hormone and testosterone and be 70 and, and look like this in those kinds of ways. But in the absence of all of that, one of the big things is this general idea of use of weight. As we age, most of what happens is we just stop doing things. So if you can continue to do even some of it, you can prevent a lot of those things. Okay? So you name it, resistance training improves it in older people. Okay? It improves everything. Right? Mobility, activities of daily living, functional independence, lowers fall risk, better bone density, improves metabolic health. Okay? So it can work to prevent type 2 diabetes. It can work to lower LDL cholesterol levels. It can lower blood pressures and things. So there's lots of these really, really good things. Okay? This may seem very obvious to you guys, but it's not been that long ago that we didn't know this, that we weren't sure just how beneficial exercise was to older individuals. Okay? So here's a paper from 1990, all right? And so in 1990, I was 12, I guess. So that was well before most of y'all were born. It's not been that long ago, but there were 10 very old participants, 86 to 96. They lived in a retirement home. They had lots of different complications. There were chronic patients that had high blood pressure, coronary artery disease. OA stands for osteoarthritis, osteoporosis. They had them do progressive resistance training for 8 weeks. All they did was knee extension. Sit down, kick out. Sit down, kick out. Okay? 80% of 1 rep max, 8 reps, 3 sets. Pretty standard stuff. Do it a couple of times a week. Up until this point, we weren't sure that we should do this in these very old individuals. What they found was over 8 weeks, almost a 200% increase in strength. Okay? Much, much stronger. Their walking speeds went up about 50%. A couple of those 10 folks no longer needed walking aids. Several of them previously couldn't get out of a chair by themselves, were now able to get out of a chair. They decreased their functional disability. Okay? 8 weeks. Very old individuals just doing knee extensions. Voila, we've had this dramatic impact on their quality of life. Okay? So next Christmas, buy your grandparents a knee extension machine. Tell them they got to put some weights on. Give them some ankle weights and come sit on their bed and do some knee extensions. Okay. So these were people that were not in great shape. They had suboptimal nutrition. We only trained one muscle group, and yet there were very, very, very sort of large improvements across the patient. Okay. So then that raised the question, all right, well, that was, 3 sets of 8 at 80%. That's a pretty high intensity. We all have to lift like Arnold here. Arnold didn't have to lift like Arnold because he was on steroids. But we need high intensity. Would a lower intensity? You tell your grandma, I need you to lift 80% of your 1 rep max, and she may be like, no, I'm not really doing it. Okay? What about some lighter weights? Okay. So we tried 3 months of low intensity training, 5 days a week. These were some women that were about 60 to 70. Okay. They said lower, okay. It was 60 to 70 rather than 80. It's a little bit lower, but they could also be 50. They found that even some lighter weights also had relatively similar effects. Okay. So we can do this. It can be safe, it can be very, very effective, and we can prevent a lot of the declines that we're going to see if people just let's see where we are before we get into the aerobic system. We'll keep going. Okay. So up till now, we've talked about muscle, bone, nervous system. Okay, kind of resistance training related things. Let's talk about the aerobic system, so the cardiovascular system, the respiratory system, how the mitochondria in your muscles are going to work. Okay. I have bad news for you guys. Your VO2 max is probably as high right now as it's ever going to be in your life. Because your heart rate's going to fall, some other equation, your cardiac output's going to fall. It's not a great place to be. Okay? In general, people tend to lose about 5 mLs per kg per minute of VO2 max per decade. Okay? So you guys estimated yours. If you were at, let's say, 40 right now, by the time you're in your early 30s, it's going to be 35. By the time you're my age, it's going to be 30. Okay? So on and so forth. You need a VO2 max of at least 12 to about 15 mLs per kg per minute to be able to walk around, to be able to do kind of normal things. This is often termed a functional threshold. So while there's a strength threshold to function, there's also a VO2 max threshold, okay? And so you're going to need this to be in a certain place. So if you're at 40 and it declines 5 per decade, right? By the time you're about 70 or thereabouts, you're going to be way, way down here. That can be a real problem. Okay? This is also accompanied by changes in the cardiovascular system. Your blood vessels, because of an accumulation of atherosclerotic plaques, they're going to stiffen, and they're going to be less compliant, and so it's going to have a harder time adjusting to changes in blood pressure and changes in blood flow. You also see weakening in the respiratory muscles, so your diaphragm is going to weaken. Your intercostal muscles are going to weaken. And so for some people, respiring or breathing is going to become difficult. That's going to fatigue faster, et cetera. Okay? So the effects are pretty much similar in men and in women. Here we're going to look at, this is VO2 max. This is in some pretty highly trained athletes, okay? But you will even note, like here are people, we've got a cross-section study, the longitudinal study, but even in these folks that were very fit at like 45, so dudes that have a VO2 of about 60 at 45, they're very, very fit. Even they are going to, they're going to see some decline in the midst of this, and then the women are going to all decline the same way, okay? You can imagine if you've not been this fit, you're starting off much, much lower. At that same slope, you can have real problems. Okay? So this is Dr. Pinku's father out with the Israeli Walking Association. He walks marathons and does things for them. But Yair puts this in because his father is very, very active, and it shows that he can prevent a lot of these kinds of things. What I want to draw your attention to, okay, is look at this line up here on the top, okay, where we have runners, people that were very, very fit. So these are kind of elite distance runners. VO2 max is about 70 when they were 20. So these are like collegiate endurance athletes. I want you guys to note, though, that our folks that are in the blue are these people that maintain kind of high-intensity aerobic training as they age. Red, they did some training, but they reduced it. And then the folks in the black here were folks that stopped training altogether. So you will note that these folks decline very, very quickly. And then while there is some inexorable decline due to aging, when these folks were training, they kind of were in a much better shape than the folks. Okay? So that's a really important thing to keep in mind. Whatever you've got right now, you can probably increase it some, but you can certainly attenuate and prevent some loss over time. Okay? This is one of the world's most famous exercise physiologists. His name is David Costel. Okay? And while his posture is not great, we're not going to give him too much grief for his posture, because he's like 90 and still runs marathons. Okay? So what do we know about aerobic training with people as they age? It's very similar to resistance exercise. That if you can maintain training, it will still continue. Okay? It can attenuate the decline in maximal VO2. That's because it attenuates the decline in stroke volume, it attenuates the decline in cardiac output. You're more mobile, your ADLs are better, improves your metabolic health. It really, really, really helps with blood pressure and a development of type 2 diabetes. Okay? So we should try to do that. Okay. So what I want to do now is let's go ahead. Let's take a break. We'll start back at 11:50. And we'll talk about a couple of functional tests and things that you can do in older individuals to assess how are they doing and how able are they to kind of live out in society. Okay. So frame this in the best way. So how many things have you done this morning? When you first got up, what did you do? Brush your teeth. Okay, good. What else? What came next? Bathroom. Okay. Take your medicine. Okay. Change clothes. Okay. Went to Starbucks. How did you get to Starbucks? You called. You go up and down the stairs? You get out of it. Okay, I just meant more like where you live on the stairs. Okay? You went to Starbucks, then you came here. Okay? You parked your car somewhere, and you had to walk to get here. Okay. Okay. Reasonable. Reasonable. Okay. Somebody else. Mitchell. What did you do this morning? Okay. Okay. What'd you cook for breakfast, if you don't mind me asking? Okay. Super keto breakfast. Good. Okay. Okay. Did you drive here? Did you walk here? Did you ride your bike here? Where'd you park? Okay. Okay. Anybody else do anything kind of remarkably different than that this morning? No? Did you tell me what you did? Okay.
Laundry, did the dishes, ate
Okay.
breakfast, worked out, ran
Okay. What time did you get up?
at 6.
Oh, that's not that bad.
Yeah.
It's not that bad. Okay. There's many days I'm up at 6 because of the toddler. Okay. Okay. So, how do you know if I told you, let's just say, Rhea, if I told you that you're going to have to recreate exactly what Mitchell did tomorrow morning, you think you could do it? Like physically, you think you could, you may not have a garden in your, in the back or whatever. I'm not picturing Mitchell like out, like walking in the garden and things. It seems very lovely to me. All this thing. Okay. Do you think if I told you that you had to go and do Kelly's workout, that you could do Kelly's workout? Probably. Okay. Okay. So, but like, how do you know that? Why do you imagine that you can do those things? You're at a good age still. Okay. Okay. Sure. Sure. Are there things that I could ask you guys to do in the morning? Maybe you couldn't. Maybe. If I said, like, go out here and flip over some monster truck tires or something, right? Maybe you couldn't do that. Okay? So from a physical standpoint, there's not a lot that you guys have to worry about, okay? I don't want to have a Toby Keith song, but you're basically as good as you're ever going to be. Whatever, something in that way. Right? So we've not got a country song. Now think about what you did this morning, okay? And think about if you have a grandparent that is still alive. If your grandparent could do it exactly as you did it, okay? Think about if they can do it, okay? I don't know, if maybe you're in the shower, you like stand on one foot or you do something, a little bit more difficult. It requires some balance and some coordination, up and down stairs, onto and off of the toilet, okay? There are going to be things that you guys take for granted. I know I mentioned this before. You guys take it for granted that some people can't do, right? And so the problem that we had as a community of exercise scientists, as a community of people that are interested in health and rehabilitation is, how do we test to know if somebody can do all of this, okay? So like we know what Mitchell did this morning. How would I know? What test could I ask Katie to do that would let us know if she could do what Mitchell did? Katie, what do you think? What could I have you do? If I had you go do squats or bench press, do you think that would tell us if you could do what Mitchell did this morning? Okay, do it at the same time. Okay. So I can tell you guys that if we had Katie do squats, that probably gives us a pretty reasonable kind of thing about what you can do and what you can't do. But the problem that arose was that we do a lot of kind of strange things in our everyday lives. And there's not a good way to test, like, can you put your clothes on by yourself without having you put your clothes on by yourself, right? It's hard to know how many cans can you put in the grocery bag and carry, unless I have you put cans in the grocery bag and carry it, okay? Many of you probably don't make your bed every day, but that's probably a choice. You could make your bed if you wanted to, but there are some people that can't. And so this is a very, very, very long preamble, okay, to trying to introduce this particular research paper that was written by a woman who was on my dissertation committee, Elaine Kress. And Elaine came up with this when she was at the University of Washington, which is where she was before she went to the University of Georgia. So they came up with something called the Physical Function and Performance Test, PFP, right? And what they tried to do was figure out, can we ask people that are older, or really people of any age, to perform a series of tasks that very closely mimic things that we do in our everyday lives, okay? There's a laundry task, okay? You have to carry groceries. You have to do a 6-minute walk like test like what you guys did. Very similar, okay? And there's also a maximal strength. There's a whole bunch of other kind of things. You make the bed and they wanted to develop a test that would tell us relatively reliably whether or not Lindsay can live by herself, okay, and do all of the things that she needs to be able to do every day. Can she feed herself? Can she clothe herself? Can she go to the store if she wants to? Are you capable of living by yourself, or do you need a little bit of help and assistance? And so out of all of that was born this particular test, okay? They wanted to identify a threshold for functional independence. That's what it's called. When you can live by yourself, that's called functional independence. Do any of you guys have a grandparent or a great-grandparent potentially that has had to go to an assisted living place? Okay. A couple of you guys. Were they happy to go to that place? Sometimes it's yes, sometimes it's no. My grandmother went happily. She was like, whatever, I'll go. This sounds awesome. There'll be people to help me a little bit. I get to play cards and watch TV and talk to people. It's great. Okay? Her husband, my grandfather, did not want to go. Right? He didn't want to go. And resisted. So that's what this idea of functional independence. So they did a bunch of different things, okay? And they came up with this functional assessment of the CSPFP. They also then measured VO2 max in those people. They measured knee extensor strength in these people. And they tried to figure out, right, like, is there some PFP score that kind of correlates to that minimum threshold value for VO2 max and to some values for knee extensor strength. So the CSPFP, it stands for the Continuous Scale Physical Function and Performance. Okay? And so here's some things. So they determined that from a VO2 max standpoint, you have a functional threshold of about 20 mLs per kg per minute if you look at it as it relates to your score on these functional tasks, so which I'll get into in a few minutes. But you'll note how here are people that had very, very low peak VO2s, and we had folks at a peak VO2 of like 5. Okay? Some of you are at 5 right now, right? Writing or typing, you're at 5. That was these folks' max, okay? But you will note that their scores tend to kind of go up, and then you hit a place in here, and then once you're at this level, then your PFP score tends to be pretty kind of reasonable after all of that. So these are the people that right about here you're going to be functional independent. So they thought you needed VO2 of about 20. Okay. Similarly, there was this 2.5 Newton meter knee extensor function threshold. Don't worry about what these units are, but the idea is that the relationship looks about the same. If you get below some critical threshold on both the PFP and this, then your scores are going to decline. And once you get over something, then you're kind of all over the place. So they can use all of this to identify a score on the PFP that says, if you reach this place, you can probably live by yourself. Okay? And so this thing, the way the test works, it assesses cognitive function. Things like eating, bathing, dressing, walking. Can you transfer yourself from a chair or something that they call toileting, which is exactly what you think. Can you get and sit down on the toilet and then get yourself back off the toilet? Okay? There's some balance that's going to be required, some fine motor function, flexibility, strength, endurance. It encompasses all of these things in the task that it asks you to do. And so you get a score based upon like how quickly you can perform a particular task, like rising from a chair and walking 6 feet. Okay? Or you get a score for I put this many pounds of groceries in my grocery bag and I carried them this distance. Okay? And you use all of that together to get some kind of big all-encompassing score that tells us how well you generally function. Okay? There are also, and this is not part of the PFP, but there are also some questionnaires that we can give people. Okay? There's something called the short form SF36 that has a physical function scale in it. This is a very commonly given questionnaire. It measures a huge number of different dimensions, but it has a physical function scale. And it will ask you questions like, how easy or difficult is it for you to get out of bed? Or how easy or difficult is it for you to reach up and grab something out of a pack? And there's some other ones, but they kind of all are measuring the same thing. The goal is just can people do similar things. Right? There's some other tests that you could do. Some of them are incorporated into the PFP with this time to get up and go. You're in a chair, stand up, walk 6 feet. Okay? There's the senior fit test, which we showed you guys earlier in class, which is how many curls can you do, and how many like chair stands can you do. There's a timed button test. You're going to press a button and it sort of pops on at certain times. There's a functional reach test where we measure shoulder mobility and things. And so I don't know all this. Okay? We go through what these things are. Not that big a deal. I'm not going to ask you guys kind of the specific stuff that goes into all of it. I just want you to be aware of this. These are all things: the functional reach test, right? The single arm curl test, the stuff that's in the senior fit, the time to get up and go. These are things that occupational and physical therapists use to assess function. Okay? You can learn about how well people can do things based upon all of it. Okay? And so there's other kind of comprehensive things. Prior to one of our faculty retiring, we had a version of the PFP set up in this very room. You have to like get clothes out of the dryer and fold them. That's one of the tasks. So there was this old like busted up dryer that was there. There's a thing where you take like 12 scarves and throw the scarves on the ground. You got to pick up the scarves and like put them back in a basket and things. It is some what you guys would think of as very, very simple menial tasks. Okay? But I can tell you that we used to go up to the lab where it was developed in Georgia and try to run ourselves through and try to get a perfect score. And we couldn't. Like you know how the test is supposed to be done, and you still can't like make 100 out of on those conditions. So, but it can be a very, very valuable tool. There's some other indexes, but that's one of the better ones. Okay. I'm not going to ask things, but here's part of the PFP. You have to walk up some stairs a few number of times. Here's the kitchen. You got to load up your grocery bag and go for a walk, cover some distance, walk up the chairs. You'll note that my man has a little harnessing thing on where you can hold on to the back of them in case they fall or they stumble. We're going to do the 6-minute walk. We can estimate part of their VO2 max and all of that and do some other things. And so you get all of these different kind of things, okay? You got to put on a jacket. You got to reach. There's the scarf pickup. You have to pour water from one thing to another. Okay, so there's a whole bunch of other things. So you can do some of these other kinds of assessments. You can do a very simple grip strength assessment, and you can get some estimates. Okay. So the last piece that I want to give you guys, and I want you all to take away from this, is in general, we should train old people just like they're young people. We should train middle-aged people just like they're young people. I should train just like you guys. Okay. With a few modifications for initial strength and a few modifications for functional limitation because of a lack of range of motion or for fall risk or something, it is okay to ask older individuals to work out at 60 or 70 or 80% of one rep max, or 60 or 70 or 80% of VO2 max or heart rate reserve from an aerobic standpoint. You must appreciate that for them that might be walking. Okay? But it's okay. Pretty much the same things. Okay? 5 days a week, 30 minutes a day, get a couple of days of strength training. Think about doing stuff where you're working on flexibility. Okay? Pretty much the same recommendations that we have for older individuals as younger people. Okay? I cannot emphasize to you guys enough how unbelievably important it is for quality of life to maintain training and maintain activity. Okay. Okay. All right. That is it for today. I will post today an Excel spreadsheet that has your ID number in it, has your age, your height, your weight, your BMI, your BIA, percent body fat, and then the 7 skin folds that I picked out for you guys based upon what I have from other classes. Okay. I have a new version of the lab that I'm going to put up for you guys. It's going to tell you what I want. There's no real write-up for this one. There's some questions to answer. There's some graphs to make. Do those things. Turn that in. You don't have to have a narrative with an introduction and a methods and a results and a discussion. You don't have to have that this time. Okay? All right. I also posted your final project. Now that we've done this lab, or we're about to do this lab, you guys can work on the final project. I have given you fake data that looks like what you did in all 3 labs. You're going to have to do some calculations with that, make some assessments on this particular individual about where they fall. You're going to have to go back into your old labs, pull up the normative values, kind of figure out where this person is doing okay, where they're not doing so okay, where they're doing great, and then make some exercise recommendations using the FIT principle and the PROS principle for both aerobic and resistance training. So it is an assignment that is meant to tie together so many of the things that we've done in class. It is due on Friday, May the 7th. So you've got 3 weeks or whatever, almost 3 weeks to get it done. Okay? But I want to go ahead and give it to you now, but you've got lots of time. You can look at it. You can ask some questions. You can work on it. The Dropbox is open. If you get it done today, you can submit it today. Okay? But there's some information on the back end, on the back of it, on the very end about like what you need to turn in, what I'm looking for, kind of how the points breakdown is going to be for everything. It should all be there ready. Okay? Questions, comments, concerns? Okay. Okay. You guys have a good weekend. Make good choices. If you did your lab stuff for me before class today, please make sure that you have either written it down and given it to me, or emailed it to me, or texted it to me. Okay? Okay.